So my talk is about robotics and revision knee arthroplasty. This is something I started doing recently, so I will share. Are you guys hearing me okay?
Yes, we can. Loud and clear.
Okay, great. This is my disclosure. So we know that the burden of knee revision is going to go up. Yeah, we know the burden of knee revision is going to go up because the primary knee replacement is going up. And we know that 5% of all TKA for osteoarthritis will require revision in 10 years. So if we ask the question, how do partial knee conversion to total do in comparison to a revision and a primary? The answer is worse after 10 years. They have a worse revision and conversion compared to primary and revisions. And the reason for that related to instability, stiffness, and aseptic loosening. And these are all things that we could improve on. And if we look for reasons for revisions, why revisions fail, we see that infection is number one, followed by aseptic loosening, instability, stiffness, because joint line is not restored. So we can improve on aseptic loosening, instability, and restoration of the joint line by improving our knowledge and maybe using better tools. So revision knee arthroplasty is very challenging and demanding. And part of the reason we have bone defects, we have a lot of instrumentation, which create complexity to the OR nurses and the staff around you. And sometimes putting and fixing these bones to osteoporotic bones with defects sometimes is difficult and leads to inaccuracy. And then your bone cuts are done a lot of time with free hands with the saw because of the reason. And this is a common practice. We know these are the bone defects. And when you have these bone defects, this creates kind of how stable is your jigs when you put them with these bone defects and how accurate they are. Of course, with the surgeons' experience and that, they improve on it and they help to kind of get the things done and the job done. But we've seen like reasons for joint not restored leading to joint stiffness and instability. Zonal fixation, this concept of zonal fixation is very important and we are all aware of it. We need to have at least 2 zonal fixation. A lot of the time in these revisions, the epiphysis is very soft and difficult, like we have defects. So you didn't get fixation in the epiphysis. So you have to go to zone 2 in the metaphysis and zone 3. So you have to get 2 zonal fixation. Now in my practice and all my revisions, I'm using 2 zone fixation, using a cone and a short cemented stem. And this is my standard practice now. So how can robotics help in revision knee arthroplasty? I think it helps by improving accuracy and improves your OR efficiency by using less tray, easier setup, and less manual handling, which I think this is going to contribute to decreasing, hopefully, infection rate. Using a software that you could plan and streamline, hopefully decrease your OR time and complexity of the surgery. So we know that the robotics being introduced, this is the robot that I use. I started with Uni in total and recently starting to use for revision. The software that we are currently using, bear in mind that this is a primary software and the revision software with the augments and the cones will be launched by the end of this year. So I'm going to share with you 2 cases that I've done here. So this is a conversion from Uni to total. This patient had a bilateral partial knee replacement performed 5 years ago. The patient's been in pain since the surgery. She came to me and she's complaining mainly on the left knee. So, you have to do your workup and find out why this uni failed. So infection workup was negative, and then we did a bone scan. Bone scan showed increased uptake medially. Of course, on examination, it was not overcorrected, undercorrected. The knee was stable, patella was striking well, but she was in pain. So I got a CT scan. Unfortunately, I don't have the image to share with you, but I will share with you this intraoperative finding. So you could see the femur is way external rotated, leading to edge loading, and this edge loading led to pain and early failure. So the way to do the surgery, you put your pens and then you map your femur and map your tibia and get your gaps. And then once you get this information, you come to this screen. So from this screen, you could plan your femur first, and this is how I always start my workflow, start with the femur and the coronal and axial. Because this is a uni, my advice and tip for this case, you have to use a transepicondylar axis, because you don't know what they did previously. So whenever I'm mapping these, I use transepicondylar axis. So I go parallel to it, and then I know how much external rotation, and then I will balance my rotation based on the soft tissue information that we have. So here we could see by all what we need to do, we could see the implant thickness on the femur is implant thickness, and on the tibia is the same. So the only thing we need to do just to improve and increase poly size. So we increase the poly size to size 15, and we can see the knee is nicely balanced. So now I know I just need to go and execute my plan. So this is what I did. I performed all my cuts and just left the implants at the end, and you just remove the implants, your femur and tibia. So this way you are below the level, and you know exactly, it's very soft. You could remove it easily with ease. And then once you remove your implants, femur and tibia, you could use the burr just to execute over that area. Make sure that you are flush with on the target level. And this is how the post-op X-ray looks like. So this is another case. This is a revision. So this patient had a bilateral total knee replacement almost 7 years ago, and she's not happy with the left side. She's complaining of a varus thrust and instability. So if we analyze this image, we could see that the left knee is in varus. And rotation-wise, the patella is good. So rotation looks all right, but you could see from the sagittal, there is a patella baja. So probably there is excessive distal femur cut, plus the femur slightly anterior, causing overstuffing of the patellofemoral joint. So you need to know why you are going inside. So this is very important. Your preoperative workup is paramount in revision. That wouldn't change. So infection workup is done, was negative. And we know that this is well-fixed implant with malalignment. And the femur need to be addressed, and also the sizing of the femur. So the workflow is like this. You start your workflow with the preoperative workup, and then exposure, just like a standard exposure, followed by pin placement. So determine your stem size, length that you will be using, and you will go 20 millimeter below the stem. So put your tibia tray usually I put it about 160 millimeter from the joint line. And my femoral pin placement, I put them anterior to posterior, slightly medial, just to avoid my cone and stem preparation. So once that is done, all what you have to do free image collection using infrared technology and building up your model. Second step. So you collect the free collection. Always use transepicondylar axis because we don't know what was the rotation that they used intraoperatively. You can check if the component was mal-rotated or not. So here we dialed, it looked like the component rotation was good. And I use the special marker just to mark the edge of the metal. And then you collect the soft tissue information. So this patient had a malalignment of 16 degrees varus. And we could see the soft tissue imbalance, too tight medially and very lax laterally, leading to a varus thrust. So this is the information, confirm what we knew. So now what we do, we go and remove the implants and then use a special marker where we have the defects. So step 3, this is what we'll do. So you just remove the implant, and then the planning for the revision compared to the primary, because this is, remember, still a primary software that we're using. So minimal base plate poly should be 13 millimeter to accommodate for the difference between revision and primary base plate. So whenever you're planning this on a software, use 13 millimeter poly. And then very important to know, whenever you are using revision, you cannot play with the slope. So slope going to be 0. Your flexion of the femoral component is going to be 3 degrees. And then your varus valgus positioning of both femur and tibia are with 2 degrees only. Varus valgus, the same thing for femur and tibia. So we went ahead, we removed the implant. This is very important. When you're removing the implant, just make sure that you take your time, go slow, gentle, minimal bone loss, just like standard revision. So once that is done, now is planning the defect. Visualize the defect, find out the defect. I use a special marker once I remove the implant, so I know where the bone defect is and what the level of the bone we are dealing with. So there are 2 ways you could use the special markers, and this is my preference, I use this. Or you could use the elephant foot or the mushroom, you put it and see the defect where it is from the articulated plan that you have. So now you come to this screen. So here you try to balance the knee and using the polyethylene to get you to that purple mark. So on the tibia, we're using here 18 millimeter poly. So I know here I'm going to use a 10 millimeter augment and 9 millimeter poly. And then on the femur, from the plan here on the coronal plane, you could see laterally, distally, I don't have any bone loss. Posteriorly, the same, medial and lateral and anterior. The only defect is coming from the medial distal. So you go ahead and you see it and you visualize it. You could see basically the defect is mainly coming medial, and you could size that defect by the technique that we showed. So here I needed the 10 millimeter augment distally medially. And the tibia preparation is straightforward. Once that is done, then I use my Anthem component, and I check the balance, and I know the balance is good. At this point, I remove the pins, and then I prepare for cones and stem and the final implantation. And this is the X-ray of this patient. So we could see, we could address this patient's alignment, patella height, and rotation of the components. The beauty of this technique, I mean, it really decreases your instrumentation. So this is exactly what we use for this case. You need your stem preparation, cone preparation, and then your trials. That's all what you need. So decrease, for me, the system that I'm using from 15 trays down to 7 trays. And it really helps the in theater to kind of do the surgery in a timely fashion. And we don't know the data about the survival and infection rate and how they're doing. But I mean, this is something that we started recently. So we are collecting the data and we will share those in the future. So in conclusion, I believe robotic in revision knee arthroplasty is still in infancy, but it really helps with joint line and soft tissue balance. And you have a precise tool that allow you to execute and minimizing your instrumentation and cost of instrumentation. And we don't know about infection and survival long term. But I think if you have better tool to execute, must lead to better results. Thank you very much for your attention.